Welcome to the Explainer. Skin and skin structure infections, or SSSIs, are a huge topic on the BCPS exam. So in this Explainer, we're going to break down the key empiric antibiotic choices you absolutely have to know. We'll use a classic board-style case to build a super practical framework you can use on exam day and, honestly, in your daily practice too.
Okay, let's kick things off with a question that should look very familiar. We've got a 44-year-old guy, red leg, got it from a scratch on a fence, and he's got a fever. The key detail here, no raised border. Now, this case is designed to test your thinking on these infections, so just keep these details in the back of your mind as we build out our framework to solve it.
So here's our game plan. We're going to classify the infection, figure out the bug we're likely fighting, pick the right drug for the job, and then we'll loop all the way back to solve our opening case. It's a really logical flow that's going to get you to the right answer.
All right, first things first, the most critical step is getting the diagnosis right. How the infection actually looks and feels gives us so many clues. Seriously, getting this part right is the foundation for everything else that follows. Now, this slide is absolutely clutch for your exam. You have to know the difference here. Look for the keywords in the question. If you see phrases like poorly defined margins or, hey, no raised border, you're thinking cellulitis. But if it says something like elevated, sharply demarcated edge, that's your classic sign for erysipelas. And trust me, that one little detail changes everything about which pathogen you should be targeting.
And then there's the diagnosis you absolutely cannot miss: necrotizing fasciitis. This is a true lights and sirens surgical emergency. So on the exam, if you see buzzwords like crepitus, which is literally gas in the tissue, or bullae, those are large blisters, especially in a patient who looks really, really sick, you've got to be thinking necrotizing fasciitis. The treatment here is a whole different ballgame. We're talking extremely broad antibiotics and getting that patient to the OR stat. Okay, so once we've nailed down the classification of the infection, we can make a really good educated guess about the specific bacteria we need to go after. For your bread and butter non-purulent cellulitis, we're almost always dealing with two main culprits: Streptococcus pyogenes, which you probably know as group A strep, and methicillin-sensitive Staphylococcus aureus, or MSSA. So whatever you pick first has to cover both of these guys. And this is the million-dollar question for any SSI case you're going to see. Do you need to cover for MRSA? Getting this right is what separates a good answer from a great one. You really don't want to use a big gun MRSA agent if you don't have to, but you also cannot afford to miss it if the patient's at high risk. So before you even think about picking an antibiotic, you have to scan the patient case for these key MRSA risk factors. We're talking about things like penetrating trauma, a history of IV drug use, any purulent drainage, that's just a fancy word for pus, from the wound, or if they have a known history of MRSA colonization. If you don't see any of these, you can stick with the narrower drug. But if you see one or more, you gotta add that MRSA coverage. All right, we've classified the infection, we've identified our target pathogens. Now it's time to pick our weapon of choice. I love this chart because it's such a great visual for understanding cephalosporins. For skin infections, which are caused by strep and staph, both gram-positives, we want to be right at the top of this spectrum. And that's exactly why first-generation agents like cefazolin are such workhorses. They have awesome, focused activity right where we need it. And this table just drives that point home. For a patient who's in the hospital with uncomplicated cellulitis and a low risk for MRSA, IV cefazolin is a fantastic choice. If they're stable enough for oral therapy, then cephalexin or dicloxilin are your go-tos. See? Simple, narrow, and super effective. But if those MRSA risk factors we talked about are present, then the playbook changes completely. Now you've got to reach for one of these big guns. And notice something really important for the oral options. You still need to add a beta-lactam, like cephalexin, to make sure you have solid strep coverage. Doxy and Bactrim can be a little weak against strep on their own. That's a huge point for the exam. Okay, it is time to bring it all together. Let's go back to our patient from the beginning and use this systematic approach to crack the case. Okay, so let's check back in on our patient. 44-year-old guy, warm, red leg, he has a fever, and that key phrase, no raised border. Now, let's run this through our three-step framework and see what we come up with. Okay, step 1, classify. That no raised border description is screaming cellulitis. Step 2, identify the pathogen. There's no mention of pus or any other MRSA risk factors, so we're targeting the usual suspects, strep and MSSA. And finally, step 3, pick the drug. This means we need a narrow spectrum agent that's going to hit both of those bacteria hard. Using this logic, we can just start knocking out the wrong answers. Penicillin G would be great for erysipelas, which is mostly strep, but it's not reliable enough for the Staph aureus we're worried about in cellulitis. Piperacillin/tazobactam? Way too broad. That's like using a sledgehammer to kill a fly. Total overkill. And apixaban? Well, that's an anticoagulant for blood clots, not an antibiotic. That's in there to make sure you're paying attention. And that leaves us with the correct answer, cefazolin. It has fantastic activity against both Streptococcus and MSSA, which makes it the perfect empiric choice for a hospitalized patient with uncomplicated cellulitis.
And don't just take my word for it. This quote really drives the point home. For the BCPS exam, you have to recognize that when it comes to uncomplicated SSSIs, simple is usually best. The first-generation cephalosporins are absolute mainstays for a reason.
So, what are the key points to lock in for your exam? It's these 3 steps. 1. Classify the infection based on how it looks. 2. Actively hunt for those MRSA risk factors. And 3. If those risks aren't there, you can confidently pick a narrow, first-generation cephalosporin. And that's our explainer on cellulitis. To keep you thinking, chew on this final question. A diabetic foot infection brings a whole new crew of potential pathogens to the party, like gram-negatives and anaerobes. How would that change your antibiotic choice? We'll leave you with that one. Thanks for tuning in.